Hi, I'm Marc Couturier, one of the medical directors for infectious disease at ARUP Labs. I'm also an assistant professor of pathology at the University of Utah. Conventional teaching is often that parasites are burdens of the developing world and of subtropical and tropical climates. This is primarily perpetuated by the textbooks, which show images of helminths and other macroscopic parasites being removed from patients primarily in the developing world. Protozoal gastrointestinal parasites, or GI parasites, in fact, are found ubiquitously throughout the entire world. However, there are socioeconomic, cultural, and behavioral variables that are involved in determining every patient's relative risk of acquiring a GI parasite. The GI pathogenic protozoa that are endemic in North America include Giardia, Dientamoeba fragilis, Cryptosporidium, Cyclospora, Entamoeba histolytica, Blastocystis hominis, and Microsporidia, which are in fact fungi, but they're conventionally included with the GI parasites. There are many GI parasitic protozoa that can be detected in a patient that do not necessarily cause clinical disease, and they are also generally found throughout the world. Many GI pathogenic protozoa can infect a human host and cause mild symptoms, or the patient can in fact be completely asymptomatic. Symptomatic infections with GI pathogenic protozoa are generally characterized by persistent diarrhea, which we define as greater than 14 days of duration. And often, these can resolve spontaneously, albeit it can take a long period of time for this to occur. Directed antiprotozoal therapy can help resolve symptoms in some patients. It can prevent complications, and it can prevent spread to other patients. The conventional testing mechanisms for GI protozoal pathogens includes an ovine parasite examination, or an O&P, of chemically fixed stool. The specimen is manually examined under the microscope after being concentrated, and this is typically done using a wet mount preparation as well as a trichrome stain slide. Conventional medical teaching suggests that at least 3 specimens collected over a period of 3 to 5 days should be used in order to improve the otherwise low sensitivity of the method. Importantly, the O&P does not detect Cystoisospora, Cryptosporidia, Cyclospora, or the Microsporidia. Detection of these organisms, in fact, requires an additional modified acid fast stain and modified trichrome stain. In our experience, these stains are not routinely included in the workup of suspected GI parasite infections. The O&P can detect non-pathogenic protozoa, which are reported in the chart despite not requiring medical intervention. In our experience, reporting these non-pathogenic organisms can unintendedly lead to clinical confusion or unnecessary therapy for the patient. Antigen detection methods were developed to focus testing on the most common GI pathogenic protozoa, namely Giardia, Cryptosporidium, and Entamoeba histolytica. This was done in an attempt to better streamline the GI parasite testing and focus on only the most relevant pathogens. The sensitivity and specificity of these assays are generally better than O&P, but they are narrow in scope, detecting only these 3 pathogens. They're not available in many labs. They require 3 separate test orders, and they're often underutilized when they're available. Molecular testing for GI pathogenic protozoa is an emerging diagnostic field that has shown tremendous improvements in both specificity and sensitivity over the conventional GI parasite testing. This has been shown in many clinical studies. While conventional ovine parasite exam cannot be completely replaced by a molecular test, molecular tests are designed to augment the testing for the most common GI protozoal pathogens. These tests are valuable tools in the diagnosis of GI pathogenic protozoa that are found in patients in North America. Conventional testing would require up to 3 O&Ps, up to 3 modified trichrome stains, and up to 3 modified acid-fast stains in order to comprehensively and reliably detect the same pathogens. Antigen detection testing requires 3 separate tests to be ordered, and it's not going to aid in the detection of Dientamoeba, Microsporidia, Cystoisospora, or Cyclospora, the latter having caused 3 large outbreaks in the U.S. in 2013 and 14 alone. For patients with suspected helminth infections, a standard O&P examination is still the test required for appropriate diagnosis. Stool specimens can contain inhibitors to molecular assays, and therefore some specimens occasionally may not yield results by real-time PCR. This limitation, however, is not unique to PCR alone. Antigen detection, as well as O&P exams, can both have uninterpretable results due to interfering substances. Molecular GI parasite tests are indicated for use in patients with a reasonable suspicion of GI pathogenic protozoa. Some key features that are helpful to decide whether a patient should use these tests include history of persistent diarrhea, defined as greater than 14 days, recent travel histories, endemic exposure histories, and epidemiological links to notified outbreaks. There are several groups of patients who could predictably see clinical benefit from molecular GI parasite testing. These groups include return travelers, immunocompromised patients, including transplant patients, HIV patients, and primary immunodeficiency patients. Also, pediatric patients, outpatients with complicated clinical course, or underlying conditions. So in summary, molecular testing for GI infections is an emerging field which shows great promise for comprehensive pathogen detection. Standard care testing for GI parasites is very complicated, insensitive, and often not comprehensively ordered. Molecular testing for GI parasites can potentially streamline and simplify the pathogen detection while providing excellent analytical sensitivity and specificity.